Assessment. History-wise, you're going to determine the cause of fracture. It can be any trauma. It can be a motor vehicle accident. It can be a fall. It can be an abuse. It can be pretty much whatever. Just you need to figure out the cause because it can give you an idea of how that injury happened. And one of the important things that is not listed on the slide, but added to your understanding of the situation. When somebody comes to the emergency department and they have bones sticking out, what are you gonna do? You're gonna take care of that injury because from your point of view, from the primary survey, you remember that? That's the most life-threatening, the most pain-causing, and everything else situation. What the nurses must do is that they need to, as soon as this problem is more or less stabilized, check the patient over everywhere. Because they might have more than one problem. They might have a rupture of the spleen. They might have a lot of bruising somewhere. They might have, maybe they hurt their head and we did not pay attention to this bump just because there was blood all over, and so on. So check the patient everywhere after the initial cause of their visit to the emergency department is stabilized. Then, if patient use substances, what's your extra intervention?
Narcan.
I mean, if they're in the respiratory distress and not breathing, or breathing like 3 to 4 per minute, then yes. But what if they're just using substances? They came in because they were so drunk, they fell somewhere off the roof, and they fractured their hip. So we're fixing the hip, but they are under influence.
You can't give them,
Can they consent?
if they're drunk, if they're under the influence, you can't
That's a
give
good
them
question.
certain medications.
Yes, and you put them on the SIWA COWS protocol. That's the answer for this question.
What is it again?
SIWA.
CIWA.
WA-AR, the full, we call SIWA, but it's SIWA-AR. And COWS for narcotics. And if they use something very special, like antifreeze, or who knows what, combined, then you call Poison Control Center, and they will guide you what to do. Labs. What will H&H give you?
Just a bleed.
Bleed, yes. And it can give you an idea that there is some bleed, or maybe the bleed is very significant and the patient is in hypovolemic shock. What's the number for phosphorus? So, potassium, albumin, and phosphorus, same numbers.
3 to 5.
Yep. Check them, it's for NCLEX and general understanding. In your hospital, there might be slight variation, a little bit here, a little bit there, but it's easy to remember when they're clustered together. Okay, imaging, self-explanatory. Nursing diagnosis, we discussed more than just that, so I'm not stopping here. So I will give you a few cases and tell me what is your first priority for this patient. What is your biggest concern and what you're gonna do. Patient fell off the tree house, head down into the pumpkin patch. And
Airway.
when fractured, their neck.
Airway.
Airway. Patient, was in a New York City bus during the rush hour and was squished and squeezed so tightly that they sustained a fracture in their ribs, 2 ribs.
Airway.
Breathing.
Breathing, not airway, breathing. Okay. Patient, just slipped on the ice and fell and fractured their upper arm.
Circulation.
Patient, fell somewhere and fractured their ankle.
Circulation part 2.
Maybe circulation to that area. Okay, what else?
Pain.
And pain.
Pain.
Yeah. So, pain is critically important for all fractures, but in some cases, ABC come first. Keep this in mind. Yes, there might be excruciating pain from the rib fracture, but it's not our primary concern. Our primary concern is patient's breathing. All right. This is easy. Let's look more at the hip fractures because they are showing up in NCLEX all the time. These are the locations where the fractures happen more or less frequently. 2 most common: intertrochanteric fracture and fracture in the neck. They are also the ones that heal worst and longest.
Which ones were they? You said in the neck?
In the neck, intertrochanteric.
Okay.
Like, this is trochanter.
Okay.
It has upper, major, and minor part. And so if fracture happens here, that's the problem. Patient, when the fracture is here, it's easy to connect. When it's here, it might be not as easy. Plus, part of the bone is enclosed in the capsule, like joint capsule. The manipulation within the capsule are always more complicated. It takes extra healing, and it's more painful and more risky from the infection point of view, especially if cartilage is involved. Other fractures of the lower extremities. So, they're easy, but where is tibia and where is tibia?
Tibia's on the outside.
Yes, but where? Where? So if you have
Tibial is on the side, right?
they're both on the side, one on each.
So
So that's a human in anatomic position.
here,
Sorry.
or is
That's
it
the
here?
thumb. That's the thumb. Sorry, guys.
The cutest little gingerbread man I've ever seen.
So in the leg, there's one like big femur and 2 bones. So which one is tibia? Which one is fibula?
Outside.
One,
The back one's tibia.
The outside's tibia.
the one that is medially is tibia.
Ah, shit.
That's tibia right there, and the inside's tibia, right?
Yes,
The right
inside,
side is-
medially. The correct word, anatomic word, medially. Medial is closer to the midline, core. And this is fibula. So tibia, fibula.
You know, you guys can with that? the pulses, when you take the pulses and you document it, post tibia.
Well, half of the group does ear scratching like this. Is this how you scratch your ear?
No.
Not unless my arm's broken.
Well, why on earth then you check posterior tibial pulses like that? You just do it like this?
Yeah.
Why are you like hugging? I mean, I've seen it more times than the regular times.
It's not me.
It's like scratching your ear like this.
I'm gonna do something backward, but maybe not that one.
No, seriously. Remember that tibia is medially. Which one is thicker?
The
Tibia or fibula?
The fibula?
Oh, by your ears. Tibia is thicker. Absolutely. Fibula is small. It looks like an arrow.
Okay, so like a fib. Okay, fibs are smaller, tibs are bigger.
So knowing that,
Big
if the
tibs.
fibula
I got
is
big tibs.
thin and lateral, so kind of less protective. Which, it's not flimsy, no, it's connected to but it's thin and lateral, away from the core. So which bone has high risk of fracture?
Fibula.
Fibula.
Okay.
Okay, but if
Is that a
that
quick
bone
question?
is, yes, which bone out of those two more prone to be fractured? Fibula, because it's thinner and it's more, it is lateral. About fractures of the chest and pelvis. We discussed that ribosternal fractures, the first thing that we assess is patient's breathing. Please recall flail chest. Remember we did this in one of the previous weeks. It's when multiple ribs are fractured in multiple times, and those ribs are located together, like rib 3, 4, 5, 6, not like one here, one there. And then the part of the chest shows paradoxical movements with inspiration and expiration, flail chest syndrome. Pelvis fracture. There are two types, weight-bearing type and non-weight-bearing type. Can the patient walk with weight-bearing type of fracture?
Yes.
They can walk because it's weight-bearing. Can the patient walk with non-weight-bearing?
No.
No. As easy as this sounds, still mistakes are made. So if it's weight-bearing, they can ambulate.
What, they can, right? Non-weight bearing.
Yes, they cannot. So, which bones form pelvis?
The pelvic bone?
Yes, pelvic bone is made of what? How many bones? The whole pelvis.
1, 2.
So, how do we call this front?
The pubic.
Pubic bone. Okay. Then, that one that is here, iliac bone, and the one that is, if you're skinny, you sit. Ischial.
Dang.
Yes.
Anatomy is my favorite.
And you have them same on the left and right. So they three here are fused in one structure, and these three are fused in another structure. In the front, two pubic connect with symphysis, which is a type of a joint. It can move a little bit, especially it can move in females during the labor. But in the back, those two bones, they're not connected to each other. They're connected to sacral. part of the spine. So sacrum can be considered as part of pelvis, and it can be considered as part of a spinal column, because it's where things meet together. Please recall this anatomy piece, it's important. Depending on which of those three bones is fractured, the patient can be non-weight bearing or weight bearing. I will not be able to draw that.
Mm-mm.
I'm just thinking how to. And I'm not sure if there is a separate bone. I don't want to hold the whole skeleton here. I'll think about maybe next break I will go and check if there are bones there that I can bring here. So if patient is non-weight bearing and requires certain positioning and there are screws there, they might be required to be in a like sling or hammock type of device for the healing. Compression fractures of the spine. The most common cause of this type of fracture is osteoporosis or bone cancer. Management for these fractures could be non-surgical and surgical. What is your main concern if there is a compression fracture of the spine at the level of before thoracic? Respiratory, yes. Because cervical plexus gives birth to phrenic nerve that goes and innervates diaphragm, the main breathing muscle. So cervical is breathing. What's the problem with mid to lower thoracic?
Digestion, like your stomach. Oh.
That phrenic nerve goes through. It innervates everything.
Legs.
It is
Walking.
autonomic dysreflexia. That is the thing that, you remember the case when the patient develops blood pressure of 200 and the fast heart rate and becomes irritable. What's going on? They have a full bladder. We need to empty their bladder, or they're impacted on the back end.
Paraplegic.
Yes. Obviously, there is no movements below the level.
What did you say?
Autonomic dysreflexia.
Autonomic dysreflexia.
The thoracic pressure. Is that, did you say like
Compression fracture
compression?
and thoracic region. What is the problem with lumbar area? And you remember the caudate minor starts at the level of like L2, 3, 4.
So it would be like bowel.
It can be bowel, it can be
I'm jumping, sorry.
urinary elimination, it can be reproduction functions. And obviously motor and sensory in the lower extremities. There is something that you need to know that is called saddle syndrome, like horse saddle. Is when the patient suddenly reports that there is a numbness in the area that where the saddle is. Genitals, inner thighs, where one would feel the saddle when they're on a horse. And that is a medical saddle like for the horse.
Oh, I thought you should settle.
I do not hear the difference between those two that you just said. That's why they probably come out the same, right?
Not settle, we're not like settle.
Like the horse.
Yeah.
This comes out better probably. That is a medical emergency. That Sadu.
Yes.
All right, amputations. Amputation is a term that indicates the removal of the part of the body. Can be elective or traumatic. Elective is, example, somebody comes with osteomyelitis and the provider says, we tried 6 weeks of antibiotics, or even, you know what, in this case, 6 weeks or 6 months, nothing's gonna happen. We need to amputate. We're gonna remove that dead tissue. The patient will say, sure, I agree. So they elect to do that. They choose to agree to the surgery. Traumatic is, well, somebody is not using protective equipment and a chainsaw themselves and things fall off. Please remember that the term amputation is not only used for limbs that have bones. Amputation can be of genitals.
Biting the ears off.
Yeah, like penis. Anything that is sticking out. Amputation of the ear. Like distal part of the body, not in the main trunk. Amputation of the nose. There are different levels of amputation. We will be looking at the extremities. Complications. When there's, for example, below knee amputation, think about complications for that specific case. Below knee.
Oh.
Below knee.
You mean like as soon as you
Yeah,
get it done?
yeah, you receive patient from back here.
Pulmonary embolism.
Bleeding?
Bleeding. Pain. Infection, yeah. Yeah. And even in that one.
Mobility.
Yeah.
Okay, deficit,
Yeah.
risk for fall,
Mhm.
hopelessness.
I hear this too often today.
Phantom pain.
Pain. Mhm.
Compartment syndrome?
Mhm.
Depression.
Yeah. Constipation. They cannot ambulate as much.
Impaired skin integrity.
Yes. Yes. Levels of amputation for the leg. So above knee, below knee, mid-foot, and side amputation to amputation. Just remember this picture, that's kind of easy. There are variations. What is good about below knee amputation?
You can still bend your knees, so when you get like your
Compared to
prosthetic, you can.
Are you need prosthetic?
Yeah, with above knee you can get prosthetic too. It's easier and cheaper to have prosthetic for below knee because patient has preserved own joint. Yes. So think about the situation when the patient has no problems with the spinal cord. Patient goes hunting and something happens during that hunting trip and he shoots himself in the like shin. And that bullet shreds both bones. The provider is trying to save that limb. Limb seems to progress in the compartment syndrome. Patient has fasciotomy. What are we doing there? And there is no movements and no sensation because there was such a significant bleed that there is quite a ischemia.
Amputated.
Well, we can fix that limb, that it is fixable, but the patient will not be able to feel or move it, because there is significant impairment. We can save the limb.
It might be better just to do it,
Why would it be better to amputate?
because you'd have more mobility and less risk for problems with the leg.
Yes, it is easier to get a prosthetic and learn how to use it and recover than to be somewhat bedridden and hold and drag that leg that is not gonna ever recover. So if there is no injury to the spinal cord and the upper part works, it's easier to have a prosthetic.
I mean, can't you just have, I mean, they have like, not prosthetic, but they have like, what do you call them? Not splints, but where it can help you walk, stabilize your leg.
Sometimes it's an option, but sometimes it is not. I know what you mean.
Because if you're gonna have a prosthetic leg, is that not just the same thing as having a leg that doesn't work? I mean, you're gonna have something plastic that you're gonna have to learn how to walk with, just the same as having your own leg that you're gonna have to drag along.
Yes, but many people who have prosthesis, they're as fast, like you, sometimes you do not even know.
Yeah, I'm just wondering, like, why would it be easier to amputate, because now you're risking hemorrhaging, you're risking infection, you're risking a lot of other things too.
But your leg's also not gonna function like it's, like you're
It's
gonna
probably
get
more
more
risk to
function
keep
out of
it.
the organ.
I mean, you're not gonna have,
Thing.
you're not gonna have nerve sensations, you're not gonna be able to feel, but if otherwise, you're fine.
It'd be an
Right.
elective amputation.
Your cells aren't,
And how do they know that your body might not just heal itself?
That is, this discussion is reserved for between the provider.
Right, I'm
And
just
that is
saying, like, I
gonna
don't.
offer amputation, but you will encounter similar questions in NCLEX. The provider explained that amputation is recommended in this case. Do not throw out this option. It's,
Oh, yeah,
it
no,
can
I
be,
won't. I'm just saying,
I'm
like,
giving you, it's not a very high yield, but I've seen this question. So amputation could be considered in this situation.
I'm sure it's like, depends on what the patient wants.
And the patient too, yes, but it's something that could be considered. All right, health promotions for amputations. And like leg health. So, diabetes is a big thing. If one is wearing prosthesis, the ulcers may develop on that callus where we put the prosthesis on. So that area needs to be inspected. And prosthetic part, it has soft insert. That insert cannot be old, it cannot be crusty, crunchy, yucky, smelly. Oh my goodness, when you put that leg, I put the legs in, or on, or into, whatever word you wanna use. And that inner part is very frequently undercarried. Let me use a diplomatic word for that. So it needs to be checked, cleaned, inspected on a regular basis, and it's not once a month. It's like daily. That sock needs to be cleaned all the time. You cannot have, and it's sweaty and then healthy weight maintenance is critical. Is it easy or difficult?
Difficult,
Difficult.
From which point of view?
because you can't, yeah, mobility.
You cannot exercise as much, right? However, people who lose extremities, they tend to, they might develop depression and not eat. Or they might develop depression and overeat. So both ways are valid, but you need to explain to the patient that you need to pay attention to your nutrition. It's very important because it will be very difficult to lose weight. So stay where you are right now. Exercise, yes. Avoid smoking, absolutely. And keep avoiding risky behaviors. Can, people with amputated extremities drive?
Yes.
Yes, they just need to have their stuff adjusted there, absolutely. All right, your nursing, like a little FYI, your nursing assessment, for somebody who had recent amputation. What you gonna do?
Neurovascular.
Neurovascular check, where?
Sorry.
Where?
Above knee.
As distally as possible, and key, compare to the healthy extremity. Neurovascular or CSM checks. Please keep in mind that grief about changes, negative changes, alteration in the body is a very valid thing. Oh, by the way, amputation is also the word that we can use in relation to the breast. So amputation of the breast is a very, very significant event for many females. And the grief over the loss of the extremity and what comes with that part of the body also. So if one lost the ability to walk and hike 15 miles a day, that's their loss. If a female loses a breast, maybe she does not feel as feminine as before. If somebody lost an ear, well, for somebody it's not ability to wear two fancy earrings, now they can only wear one. For somebody else it's a different type of a problem. But regardless, how are you gonna approach that? Acknowledge the problem and say, tell me more. That's general thing. Diagnosis, that's easy. Nothing serious is going to be about diagnosis for amputations. Stump care. So, this is how the stump is being read step by step. You do need to know and be able to take care of that stuff. It's obviously not something that the patient will be doing like a year into after the surgery, but right after it. Otherwise, it's just not gonna, it's not, the dressing is not gonna stay.
Is the bottom just, like, is that the leg or an arm or what?
The top's above the knee, the one's below the knee.
This is above the knee, and this is below the knee. Oh my goodness, we have no failed NCLEX students yet.
Oh, that's good.
That sucks.
Yes, like every single one
It's nice to hear.
Did they do Kaplan?
I do not know. As soon as they lead to 16, they don't report.
Well, they must be reporting the NCLEX.
And NCLEX results come, I mean, I can check anyone.
Oh, they
But,
come in.
like Joe and Denise and Debbie, they maybe subscribe to something, so they share in the faculty chat. Hey, we have new nurses. Hey, we have new nurses. Yeah, we have some fast. Okay,
Oh, thank you, Lord.
Yeah, I think it's me.
this mask is cheap. It's not like hospital masks.
Yes, they are. Because you've been doing this.
The paper suffocates you.
That's the only way that I think it does. Like you breathe in, it chokes. You choke.
I don't know, that one at least does not make the particles, the hairs. This one is just so.
Yeah.
So, How do you know that the patient needs to go to rehab and not home?
How do you know they need to go to what?
Rehab.
Rehab and not home.
And they cannot take care of their problem.
Lack of support, like if they don't have somebody. at
Yes,
home,
if they do not have the support, but maybe they don't need the support.
Depends on their ability to do their ADLs.
Yes, if they can take care of their own ADLs.
Sounds good. Sorry.
Don't look at me.
I lost it, but okay.
Oh, she said something smelled good, I think.
About yeah, I can smell her sub.
So,
Sub, her
The sub
sandwich.
sandwich.
oh, okay. Lack of English words, I guess. So, that is the answer. If patient is not able to do their ADLs, they go into rehab. And somebody else is not there for them, for their ADLs. It's not just ability to ambulate. It's not ability to do grooming. It's all together. They need to be able to feed themselves, cook themselves, pay their bills, transport themselves to the pharmacy, like basic living. Or somebody helping them all the time whenever they need. Which can be a family member, friend, human. If the person is not able to do their ADLs and they not have a human who can help them with that for a time of recovery, they're going to rehab. How long will they stay in rehab? Until
They can do their
they're
ADLs.
able to do ADLs, or we discover a human that can help them. So, for example, the patient is going to potentially could go home and because there is a son there. But son was just hospitalized with flu. So until patient is not eligible to stay in the hospital because they don't need the hospital setting anymore, insurance not gonna cover. So they need to be discharged. Can they go home safely right now? No. For the time until the caregiver can start taking care of them, the patient is going to rehab. And then 5-10 days, whenever the son recovers with their flu and is discharged back home and is capable of taking care of the patient with amputation, then the patient can be discharged from rehab and return home. All right, carpal tunnel syndrome. Okay, I need to change this mess. I'm sorry. Let's take a little break. I need to stretch my nose. I'm gonna lose it.